All right, hi guys. Who's got 2 thumbs up and wants to keep his epithelium on? That's this guy. Hi, my name is Brandon Ayres. I'm from the Cornea Service at Wills Eye Hospital and Ophthalmic Partners of Pennsylvania. And welcome to Best Practices in Keratoconus Management, the podcast. Now, on this podcast, we go basically around the world talking to experts about their best practices in managing keratoconus. And we've talked about a variety of things, but today we've got something really special. I am so excited about this topic. I might need a little bit of supplemental oxygen to keep myself going here. Today, we've all been waiting for the release of Epioxa. That is collagen cross-linking with supplemental oxygen and no epithelial defect. Now, before I get to introducing our guest today, let me break things down to you. For years now, we've been doing epithelium-off collagen cross-linking, and it has been one of the best things for the management of keratoconus, maybe since the invention of 10-0 nylon. It's really been a positive thing for our patients, but there are some problems with it. And we need to do better at finding every patient with keratoconus and get those patients treated. Now, that's been a little bit challenging because we have to talk to patients about the procedure. Now, that's not the challenging part, but the discussion is it can be a little bit intimidating because we have to talk about things like making an epithelial defect, soaking the cornea with riboflavin, looking at the light. How will this feel afterwards? How will this impact you going back to school or going back to work? And how long will it take before you can get the other eye done? And once in a while, I think I've had a few patients scared off from the procedure, which is really a shame because it is the only thing that's been shown to really halt the progression of keratoconus. Now, with Epioxa, I think we're going to have some answers to this. It's going to make an easier discussion, at least for me, about the discomfort, the logistics about getting back to work or getting back to school, and especially about getting the other eye done. Even the financial concerns really should be addressed by Epioxa. So we have a lot to talk about today. And today, my expert is a good friend of mine, Ken Beckman. Now, Ken, born and raised in Ohio, residency at St. Luke's Medical Center, did his fellowship out in New Orleans at Tulane. He has won every award you can possibly win. Best doctor this, best doctor that, best doctor in the world, best doctor on the space station. I mean, I don't know. I don't think there's anything he hasn't done. A member in multiple societies, ASCRS, ACOS, Cedars, Aspens. And I tell you what I love about Ken is he's the voice of reason. Whenever we're on a panel and people are shouting out about all these crazy things that they do, Ken comes in and says, wait a minute, you guys are all nuts. That's not real world. Here's what really happens. And that's why I have so much respect for Ken. That's one reason I have so much respect for Ken and why I'm so happy that he is here on this podcast about Epioxa. So Ken, thank you for being here. I appreciate you spending the time. What I want to know from you right in the beginning, and I talked you up, is what are you excited about with Epioxa? And what is different about Epioxa as compared to the cross-linking that we all know and love currently?
Well, Brandon, first, thank you so much for the kind introduction. I hope I can.
Have you ever been introduced like that before?
I have. I hope I can have the enthusiasm that you do. You sound like Casey Kasem top 40. So I will do my best here.
That's what I'm going for. I appreciate it.
I really like that. So, well, thank you again. What am I excited about? Well, the big thing is we move from epi off to epi on. To me, that is a true game changer for several reasons. First of all, we understand what happens with epi off. You're creating an epithelial defect. So obviously there are issues that patients have to go through. Number one is discomfort. Number two is the risk of infection, the prolonged use of a contact lens, scarring, haze, and really a prolonged visual recovery. Now, the results have been amazing with Epi-Off, but these are still barriers that can be a problem. So with Epioxa, we're now entering an era of Epi-On cross-linking. And that's really the big change. That's what I'm most excited about, to have a more, a quicker procedure with less risk, less irritation and pain, theoretically less risk of infection and scarring and haze, and quicker recovery. So the opportunity to do something that's less invasive and that can still give you the results that we want is really, really a game changer.
Yeah, I mean, I couldn't agree more. In fact, I literally got a phone call this morning about a patient who's 1 week after collagen cross-linking. And we'll put a pin in this for later, but now I'm a little bit conflicted about what I'm doing because I'm still doing, and we still all have to do epithelium off collagen cross-linking, but we know that we have approval for epithelium on. So we're in this transition phase from one technique to another. And literally this morning, I got a phone call and a photo across my phone of somebody post-op week 1, no epithelial defect, but a pretty steamy looking cornea. And I'm myself, I'm so excited about moving on to, to not having to make the epithelial defect just to see if, we don't see the risk. I'm sure we're going to have a lower risk of infectious keratitis because we don't have to, disturb the epithelium. And that I think is a game changer. But the whole procedure is actually a little bit different as well. And you and I were both investigators in at least one of the studies, if not both. You were an investigator in 1 and 2.
Yes.
Yeah, so I also was, and we'll get into those studies, but the whole procedure is different, right? I mean, it's not just no epithelial defect. We've got oxygen. We have a different UV source. It's a shorter procedure. It's shorter soaked. I mean, the whole thing is different. So just thinking that all we're doing is not making an epithelial defect really isn't the story at all when it comes to Epioxa. I think it's really all about the supplemental oxygen that we use for that procedure. At least that's one of the primary differentiators from it. It's not just Epi-On, it's Epi-On with supplemental oxygen. What are your thoughts there?
Well, I think that clearly you can't just take the old system and just not scrape the epithelium and have effective cross-linking. There's so much more to it, and in particular, based on the barrier that the epithelium gives. So you're right. We have to address the problems, and if you want, I can go into that a little bit of that right now, as far as what the epithelium does. But barrier number one is the drug itself needs to penetrate. So Epioxa has a unique formulation that seems to penetrate through the intact epithelium, and we can get high enough stromal concentration. Number two, oxygen. We know we need oxygen within the stroma to have an effective aerobic reaction. And the problem with merely doing cross-linking without the supplemental oxygen, the instant the light turns on, oxygen is depleted from the cornea stroma, and we have essentially an anaerobic reaction, excuse me. And by providing supplemental oxygen, we can keep oxygen concentration within the stroma high enough that you can have an aerobic reaction, which is going to be much more efficient and effective.
Yeah, so if you ever want to go back and listen to a podcast, listen to the podcast with myself and Tomas. Tomas knows more about cross-linking than anybody I've ever met. And he really gets into the difference between type 1 and type 2 reactions, which is kind of what you're alluding to, Ken. Having that hyperoxic environment allows those free radicals to stay around, and it gives us a much more efficient collagen cross-linking versus just using kind of ambient oxygen. Now, I remember the first time I'm like, oh, yeah, we're going to use supplemental oxygen. That's cool. We'll use an oxygen tank. But like, how the heck do we keep the oxygen around the eye? Right. So we use the boost goggle, which is all part of the process of Epioxa. It's not just the riboflavin, it's the whole process. But now we're going to have oxygen tanks in the office. And I don't know about you, Ken, but did you ever like put your foot on the oxygen filled tubing and make that terrible honking noise? Did you do that?
Fortunately, I avoided that.
Okay. Well, I can tell you firsthand, if you step on the oxygen tube, it makes a really funny honking noise in the office. But we use the what we call the boost goggles, and they kind of look like like swimming goggles, you'd say, Ken?
Shop goggles.
But shot goggles, but there's no lens. It's just
Right.
like a little pool for the oxygen to sit in. And that allows us to get that hyperoxic environment. And Ken, what was your experience, that first couple times you were doing cross-linking? And I know in the studies, everything was timed and checked, and we had people reading protocols and making sure you did everything exactly on time. But that setup in the room is a little bit different than what we do currently with the idling procedure and epithelium off collagen cross-linking.
Yeah, it's a little different, but it wasn't a very difficult hurdle to get through. Basically, the patient is lying there, and after they get their drops, we put the goggles on, and it's essentially, like we said, a shop goggle where the lens is gone. And there's a tube that pipes oxygen in. So there's a chamber, semi-enclosed chamber over the eye. we have a little nozzle or little probe that goes in through the top that actually reads the oxygen content. So while the oxygen's pumping, we can read that the chamber concentration gets to over 90%, which was the target. So everybody had to have greater than 90% chamber volume or chamber concentration of oxygen. So when you're doing normal cross-linking, it's in room air, which is around 20%. So at that high levels, you're getting, really, really high levels within the cornea. I did not find it was particularly difficult once we put it on, and we checked at the beginning and at the end just to make sure we maintained 90%.
Yeah, we did the same thing. What I found was just there's more going on during the procedure. And so if you recall in the trials, everything had to start within a certain amount of time. So we would actually pre-fit the goggles on the patient. We'd have them lie back. I'd put the goggle on. They kind of Velcro on, this little Velcro strap. I'd make sure they fit. Then I would take it off, so it would just kind of be dangling, on the headrest. So that way, as soon as we loaded the riboflavin, I could put the goggles on, get the oxygen going, test the oxygen concentration. Now, I probably in the real world, when we're doing these treatments in the office, we're not going to have to be nearly as regimented. But during those clinical trials, everything had to be just exactly on time. And so I was so scared I was going to take too long, and I'd be the one doctor well, we had one outlier in Philadelphia who couldn't get the boost goggles on in time.
You
So
know who that is?
yeah, they call me Ayres slow goggle putter honor.
Mm.
But yeah, it did well. But there is a little bit more to it in the office, and we're going to have to get oxygen tanks to do this. And luckily, there is kind of a suggestion guide that Glaukos has put out that helps you figure out where to source the oxygen. They don't give it to you. They can't just say, here's the oxygen, but they are very helpful in trying to help an office who hasn't had to have gas in the office get some and know where to get it from.
Right, you'll probably have to prepare ahead to have a backup tank because you don't want to run out in the middle of a procedure, and have to have somebody in the room who's really responsible for watching the level and making sure everything's going on, everything's being done correctly. But once you get used to it, yeah, there's more stuff going on, there's more hands around, but it really is not that complicated once you do a couple of them.
No, yeah, it 100%. You're right, Ken. It's not. In fact, overall, the procedure is much faster. And once you do one or two, you sort of get it, and it's actually a very quick procedure. Now, we were both investigators in the two different studies, and I think we'd be remiss if we didn't at least discuss, what those studies were, and at least some generalities about the outcomes of those studies. Ken, are you up on your study research?
I sure hope so.
All right. So first study was several years ago. This was the initial study. Ken,
Mhm.
what do you remember about that one? I'm testing your
Well,
knowledge here.
I'll test my knowledge. So we had around 300-ish patients, and they were split up 2-to-1 of treatment versus a sham arm. And the treatment was followed over the course of a year, with the primary endpoint at 6 months and the secondary endpoint at 12 months of a difference in Kmax between the treatment arm and the sham arm.
Yeah, I remember doing these studies, and they're both of them were randomized basically 2-to-1 with a sham, and it was they're parallel, they're randomized. We were masked, and we had patients who, when we would disclose whether they had treatment or sham, it was almost like a reveal party for a baby, where they had a poop emoji because then we would put them into the treatment arm, or it was like a happy emoji because they were already treated. But I was amazed at how many young patients wanted to be a part of these Epithelium-On studies, knowing that they may progress if they get the sham. And 2-to-1, there's enough that you could be receiving the sham, not the treatment. But they were so excited about being part of the study, forwarding the science of keratoconus management, and not having an epithelial defect, right? That they were willing to participate, and families were willing to have their kids participate. Now, all patients were eventually treated, even if they were in the sham groups. And I think the only difference between the two studies was, I think they flip-flopped the primary and secondary endpoints. I think in the first study, the primary endpoint was a 6-month with a secondary endpoint at 12 months. And then study number 2, which was a little bit larger, primary endpoint was 12 months, secondary endpoint was at 6. But we were looking at the same data, the same thing.
Right. Unfortunately, they both hit the target. The sham group progressed by about a half a diopter or so, and the treatment group flattened by about a half a diopter or so. So they reached the 1 diopter difference in Kmax at the appropriate endpoint. So it seemed to work really well. And then the majority of the patients actually followed through with getting their retreatment if they actually got the sham. And I don't think very many opted against it.
Now, I think almost every patient finished the study, maybe one or two dropped out. I mean, it was a very good retention rate for these patients, so we didn't lose anybody by doing the study.
Mhm.
And what I thought was really cool was there was in both studies we did a subgroup analysis looking at those younger patients, 29, 30 years old and younger. And in those younger patients, which are really the patients that we are targeting, and I think with Epioxa, Glaucosa is going to make or is making a tremendous effort at finding these patients, finding these young patients. It doesn't do us that much good to cross-link somebody who's 55 or 60. We're looking for the 14, 15, 16-year-old patients who are just kind of emerging with keratoconus and getting them treated. Although we'll treat everybody, don't get me wrong. If you need it, you need it. But in that younger population, there was a bigger delta between the treated and untreated groups, which was about 2 diopters, I think, in the first study, and maybe a little over, I think it was about 1 diopter in 1.1 or so in the second study. And these patients overall were less severe keratoconic patients as compared to some prior studies. So we were dealing with a little bit of a different population between study 1 and study 2, and also between prior generation studies. But the take home is that it works. We don't have to make an epithelial defect to stop keratoconus, but we do need to use the right materials, the right form of riboflavin, Epioxa, and use supplemental oxygen to get to the endpoint. Now, you can't talk about the good news and not talk about the bad news. So were there any adverse events, or what were those adverse events in the study?
Fortunately, there were not many. It was the things that you would expect, a little irritation, blurred vision, but compared to the previous studies that were Epi-On, obviously you didn't have the epithelial defect issues that you had before, and the comfort level was much better. So in my personal experience, I did not see a lot of people complaining about any of these. There were very few. And then the other things you tend to see, scarring and haze, et cetera, were also very mild. So it was quite impressive. I think to me, actually the most impressive thing was a point that you brought up a minute ago about the fact that we were dealing with younger people. And what it showed us was the natural course of this disease. The reason why the delta was so great in the young people is not that they responded better, but the untreated arm progressed so rapidly that in a matter of
Right.
6 to 12 months, they were steepening by 0.7, 0.8, enough that the delta was much wider. It goes fast, and you're right. You got to catch these people young before they lose vision.
So, like, look at some of the adverse reactions in the Epioxa study, right? The most common is going to be conjunctival injection. The eye's a little bit red. That was 31%. That was like 100% in
Mhm.
Epithelium-On, right? Epi defect is an adverse event, and of course, in an Epi-On study, it was 100%. In the Epithelium-Off studies.
Right.
Uh, Photophobia, dry eye pain, irritation, increased lacrimation. These are all things, anytime somebody in the study mentions something, we have to write it down as an adverse event. And you're going to get a little bit of discomfort because we do demucinate, we do sort of rub the cornea with a moistened Wexel. So there's zero discomfort, but it's a whole lot less than what I would
Right.
anticipate with a full epithelial defect. Um, and that also, that in turn, having a more positive experience with some of our patients in the Epi-On study makes them want the other eye sooner. I mean, right now, when a patient asks me, so when do I do the other eye? My answer is, we don't want to forget about the other eye, but let's just see how you do. Let me give you a couple of weeks to maybe forget about how you did on the first eye. Then you'll be willing to get the second one done. And I don't think that's going to be as much of an issue with Epioxa. What's your take on that?
I agree. I mean, we did them as close as I think a week apart. And I usually tell patients now, as soon as you're comfortable visually and just irritation wise, we go on to the second eye. But typically they may be a month apart or more with the Epi-On, or excuse me, with the Epi-Off. And I think with Epi-On, it'll probably be pretty quick.
Yeah, no doubt. I mean, I do I do have some concerns that I lose track of some patients, and we do the first eye, which is usually the bad eye, leaving
Mhm.
the good eye. Sometimes I wonder if we should do the good eye first and then the bad eye, because that's the one that's getting them through their day. But I still do bad eye, then good eye. And I bet you I have lost track of a few patients because they didn't really enjoy the epithelium-off procedure. And perhaps if we did an epithelium-on procedure, they may not have some of the same discomfort and wouldn't be quite so intimidated or scared about coming back and doing that second eye. I know that I've had some patients with infectious keratitis who said, you know what, I'll leave the other eye alone. And that's the opposite of what we're looking for. We are trying to, with the help of Glaukos, find every patient with keratoconus and get them in to be cross-linked so that we don't do transplants at all anymore for these patients. And the sooner we stop it, the less the long-term morbidity. We can, poor scleral lens fitters. I mean, maybe we can get these patients treated before they ever even need that scleral lens. They're just showing an increase in astigmatism. So I think finding those patients is really, really important.
No, I agree. I think it's interesting you brought up the first eye because I do have a number of patients who want to get their good eye done because they're afraid of it turning into their bad eye. But with epi off, the recovery was longer. And so oftentimes I'll say to them, let's get the other one done, get you in a scleral so you have something to get you through when we do the good eye. I think with this one, I wouldn't hesitate to do the good eye first and just get them on their way and get that one protected first.
Yeah, totally agree. Especially if I can say, hey, instead of scheduling one and then waiting, probably just get both of them on the books and scheduled so we can more rapidly go from one eye to the other. And then that patient's done and protected. We don't have to worry about that patient nearly as much. We can feel pretty confident that now that the cross-linking is done, we'll stop that progression.
Right.
Now, Epioxa has a slightly different label than I linked it, right? Than with the epithelium-off procedure. Are you familiar with the minor variances in the
Oh, yeah.
labeling? Yeah.
Yes.
I think this is big news for keratoconus patients. This is not their I don't know, their brother's collagen cross-linking is for
Your
sure.
brothers. Well,
Well, because they're young, so it's not like your dad would be,
yeah,
anyway.
your young uncle.
Your young uncle. There you go.
Right, right. Yeah, I think the biggest change is that they no longer require proof of progression to get this approved. And I mean, that's really important because a lot of these patients are young and you're seeing them for the first time, and you don't, or maybe the optometrist sees them and sends them to you 2 weeks later. You don't have a track record of old refractions and topographies to really prove progression. Yet we know they're progressing. They might be very steep, they have limited vision, and you're stuck at the mercy of the insurance companies to convince them that this person is progressing and needs it. Why do we want to wait until they have permanent vision loss before we even jump in? And the fact that that hurdle is going to be removed could open the door again. Talk about increasing access to patients. That could be huge because we have a lot of patients who've had to wait much longer than they should have.
Yeah, 100%. So just removing that from the label is great, but we also have to remove it from the mindset of insurance payers,
Right.
because they may now be accustomed to oh, sure, this is for progressive keratoconus. You got to show me it's progressing. And we do all kinds of background research and different tests and studies to try and make sure that we can show progression for our patients, whether it's refraction, topography, history, contact lens. I mean, you name it. And in your heart of hearts, you're like, this patient's 18 years old with keratoconus. They didn't have it when they were 15. They're clearly progressing. Let's get them treated. We also have a thinner minimum pachymetry, right? So we're sort of stuck on this 400 micron. With this is 325. So, we can treat a thinner cornea without fear of any backlash from, a payer saying, oh, you know what, your doesn't hit the criteria, it's too thin. You can't do that. So another plus for keratoconus patients, and it's approved for down to 13. I mean, I don't see a ton of 13-year-old patients with keratoconus, but we do have some. We've had some down into even 7, 8 years old. But I think having the label down to 13 is going to be really helpful when you do find that early onset keratoconus patient, or maybe you're screening a family, and you've already treated maybe a brother or sister, and now you're looking at some of the younger siblings. This is a new system. We are transitioning from epithelium off to epithelium on. There's a lot of education. You already mentioned educating, your referral population, whether it's MDs or ODs. We also are going to have to educate the insurance payers. And we are already in contact with our insurance payers saying, look, we've got a better way of doing cross-linking. I know this patient was approved for epithelium off, but I would really like to do Epioxa on this patient. It's a new code. It's a newer procedure. Let's start this conversation now.
Obviously, we're not able to initiate the treatment yet as it hasn't been rolled out, but we are working with Glaukos, and I know the process is getting started on dealing with the payers to get this accessible. I think that Glaukos is working really hard on making this accessible, more accessible to patients. And what I mean by that is from the patient access standpoint, for almost every patient, they're going to have a patient assistance program, and they will be able to get almost everybody done at no copay or very negligible copay. And I think that's really, really critical. Right now, if somebody has a high deductible, even though the price may be, 45 or 100 or whatever the price is for the current riboflavin, it may all go to deductible and their cash pay essentially. And so they're really going to be aggressive in that regard to do the patient assistance whenever possible. And then number two, take the burden off of the physician because they're going to have a third party specialty pharmacy that will be doing the buying and billing and prior authorization prior to the procedure. So the doctor would not be on the hook for buying the drug and then having to worry about getting reimbursed. So those are two big things that will increase access. And I think that the efforts that they're doing now, they have to show us that they're going to do it. And I believe they will. But I think that could really open the door to so many patients who are currently not getting treated, suddenly being able to get treated.
I agree, Ken. I have a lot of respect for Glaukos and how they're going about this. I've had a couple of discussions with the executives, and I really appreciate the attitude. They're excited that they got Epioxa approved through the FDA, but understand that the real goal isn't just Epioxa, it's reaching the keratoconic patients, especially those young patients, the patients who are too afraid to tell their mom or dad that their vision's changing or don't even know their vision's changing. These are the patients who tend to progress faster, they present with more advanced stages of the disease, and by going out and finding those patients and bringing them into the office, we're going to be able to make that diagnosis sooner and get those patients treated earlier. And I really love the idea that Glaukos is trying to make this affordable for every patient. But we have to do our part as well, and we do that by reaching out to insurance payers and trying to get our patients approved, kind of raise the awareness of this new procedure. We are already starting that, and I've got several patients who are already approved for epithelium off collagen cross-linking, and we're going to try and get them approved now for Epioxa. Hopefully over the next 6 months or so, we'll get more and more of those patients approved, and any patient who's not approved will continue with epithelium off.
I agree. And I think just to add more to the work that Glaukos is doing in the awareness department, yeah, I can't emphasize enough the gatekeeper issue, how important it is to really get the optometrists and the comprehensive ophthalmologists who are seeing these patients aware of the process and that these kids need to get in early. I tell my patients regularly, this isn't LASIK surgery where you're suddenly going to get better. This is like waterproofing your basement. We're trying to prevent something from happening, and you may see no differently than you did prior. But you want to get in early. You don't want to wait until you're full-time scleral lens dependent and you're correcting the 20/40 and you're getting closer and closer to grafts. And I think that as the awareness grows within the gatekeeper community, we're going to start getting these patients in earlier.
I think we are. And I got to thank Glaukos for investing the time and money into getting collagen cross-linking and Epioxa through the FDA studies. We got to thank our patients for being willing to participate in the studies. And thanks to practitioners like you, Ken, for helping to run the studies. It really is amazing. In just my own career, the management of keratoconus has come so far, starting with traditional corneal transplants, then moving on to lamellar keratoplasties like DAOK. We finally had FDA approval for epithelium off collagen cross-linking, and now approval for Epioxa, epithelium-on collagen cross-linking with supplemental oxygen. We're now moving into an era of interventional keratoconus management, and this is made so much easier and helped by Glaukos so we can not only detect patients earlier, but we can also be more successful and more proactive in treating with a better procedure, and that's Epioxa. Ken, thank you so much for spending the last hour or so with me. Hopefully out there, some practitioners will pick up a tip that they can bring to their own practices and their own patients, and maybe we'll even reach out to some patients as well. Thanks a lot, Ken. I appreciate it.
Thank you. Thanks so much for having me, and I'm looking forward to getting started as well.
I want to thank all you guys for staying with us on this podcast. I know I've learned a lot. Hopefully you've learned a lot. If you want to add more, please click the link in the description so you can fill out the survey and let us know what other topics you may want us to cover on best practices in keratoconus management. Thank you so much, and a special thanks to Glaukos for funding the project. Thanks for watching.